So thank you, everyone. I take advantage of the two very nice presentations that preceded mine to just present a quick case that we can discuss together in terms of process decision making about the management of degenerative mitral regurgitation, and for sure we can take advantage to have here with us the surgeons and this new technology of to use minimally invasive surgical repair through robotics. So this case is about a 91 years old woman who was really independent in her daily activities at home with a few comorbidities like diabetes, hypertension, atrial fibrillation on new anticoagulants, CKD, anemia, with a history of progressive dyspnea during the last 3 months with multiple admissions in other centers for pulmonary edema due to the severe mitral regurgitation. So at the very end, this patient was transferred to the MHI for further investigation and to discuss which are the options for her. So at the in-hospital evaluation, the patient was stable, class function was 2-3 out of 4, not chest pain, no syncope. At the echo, there was a severe mitral regurgitation, which was due to the rupture of the cords and a flail of the posterior leaflet, with a jet in A2, P2, A3, P3, with a mitral area of 5, and a TR, moderate TR, with regular dimensions of a normal systolic function of the right ventricle, and ejection fraction of 65%. So those were the hemodynamics with a V wave on the left atrium of 25 and I surgical score, raise score. So this was the TE echo that showed a big jet. This was the 3D evaluation that shows that in the medial to central portion there is a big jet of regurgitation. So to discuss with us which are, in your opinion, the option that we have, because here we can talk about medical therapy, but we know that since 3 months this patient was admitted multiple times, so it means that even with optimal medical therapy it didn't work so well. Then we can talk about surgical repair, and here we have to ask ourselves, in this patient with this surgical risk, what we can do, which are the options. Is the robotics, is the minimal invasive, and then afterwards we can discuss about minimal invasive mitral clip and in terms of procedural safety and success in terms of treatment of DMR. So which are your opinion about that? Do you have any idea?
Okay, so we'll open up the panel for discussion. So we have this 91-year-old lady with recurrent pulmonary edema with a significant MR from a degenerative cause. She has a flail leaflet. Simon, what do you think?
Well, she's pretty old. Our default, of course, is always surgery. And because of our experience, because of Mayo Clinic with my mitral valve repair, but in this case, I think interesting to see what the interventional cardiologists think. But you need a few clips. I would probably go that route to start with. I mean, if they think they can achieve some symptoms relief from that or decrease in rate of, we want to make this mitral valve perfect, but we want to mostly decrease the rate of readmissions. From a surgical perspective, if we were pushed to do a surgery, we would consider a minimally invasive approach for sure. Now, I'm worried about retrograde cannulation in a 91-year-old. So that would be I would probably work with the team and try to get this patient to a clip as opposed to a surgery just because of age.
And I think we would do, yep.
Does the patient have coronary disease?
No.
I think we would probably have the same approach of trying the clip first because of the age. Because a bit like Anta said in her presentation, the morbidity of the clip is so low. The best thing is that it's going to work, and the worst thing is that it's not going to work. And we end up operating on a couple of those people as a second try, But building up, trying the least invasive aspect and the least morbid aspect first, at least in our experience, has not played against us.
The only answer to that is if you can't fix the mitral valve, it's not better, and it's hard to repair the valve afterwards. We've repaired some, but you're kind of faced with a replacement if you have to move on with surgery, which may or may not play out.
Well, there's a tiny little lock, you know. If you have a microscope, you can find the lock on the clip and unlock it.
Yeah, but
Have it to
they
open.
put 3 or 4, though, it's a lot of locks.
Before we get Anita's comments, because of course this is coming from her center, any more comments from the panelists or any ideas?
I agree with Dr. Bouchard. That's what we would do in our institution as well. We would, of course, I would need more images to see if to assess the feasibility of the mitral clip procedure. But we would first try a mitral clip procedure, and then, if it's a failure, then you always have the option of bringing this patient to the OR.
Harindra, any comments on the case?
I mean, I don't do mitral clips, so I would say as a practicing cardiologist, anytime a 91-year-old comes in with anything, I think the biggest question for us is whether she should have anything done. And she clearly is very symptomatic, but I think in this setting, as with TAVI and other, when we consider these expensive procedures in elderly patients, we would look at frailty and all of those other things to consider. And certainly at our institution, if the decision is to proceed, it would be whether a consideration of a percutaneous one for all the other reasons that have been mentioned.
Yeah, that's an important point. What is the goal of the therapy, and what are the patient's wishes, and is there any idea of what the patient wanted before all of this? And so we're going to be going to the live case very soon. But Anita, can you tell us your ideas about the case and the potential for clipping this?
So obviously it's a patient that we had seen clinically, and she was referred from an outlying hospital because she'd been repeatedly admitted. She was previously completely independent, living in her own home, able to manage everything herself, but recurrent admissions to a community hospital with heart failure. And so obviously medical therapy wasn't working for her. We discussed it with her. We're very open with the fact that she was a good candidate anatomically. Now it's a flail, but the flail gap wasn't particularly wide. It's more than one segment, so it was P2 and P3, which can be clipped actually relatively successfully. And she had a mitral valve area greater than 5. So, technically it can be done. More importantly, clinically the patient was willing to try. She wasn't terribly interested in surgery at the age of 91, but she was interested to take the risk for mitral clip, which is minimal, the worst case scenario being it doesn't work, and that she's no better than when she started. And so we elected to go with mitral clip. If Michele wants to show the rest of the...
So we decided to go for mitral clip procedure under general anesthesia, guided by angiography and TE, and with a venous access. So now we can see that this is the first step every time when you do a mitral clip procedure is the transseptal, and we take a lot of care about transseptal puncture because this is a crucial point of this procedure. So if you fail to have a good position, then it makes your life really tough to get a good result. So usually what we try to achieve is 3.5 to 4 as a distance from the mitral annulus. But when we are working on DMR, usually we try to get a little bit higher to have more room to get the flail, while when you are working on functional mitral regurgitation, usually you want to be a little bit lower. We are usually using the Baylis catheter, so radiofrequency catheter, to get more precision in our puncture. So I don't know if you have other idea about that. So the first clip, we with 3 DTE, we get the orientation to try to clip in the middle, which is usually the standard approach we use. Then you go to LVOT view to have a better idea of grasping the posterior and the anterior leaflet. So in this case, actually, we were not satisfied with the first result when we just grasped the leaflet, and so we decided to change the clip orientation to try to have a better grasp and a less residual jet. So we came back with the second grasping attempt, and then this was the result when we grasped. So we were quite happy, but still you see that there is a jet coming from mitral valve, And so you can clearly see in this 3D reconstruction that there is still a jet on the medial side. So our strategy in this case was to keep this clip in place and try to put another clip more lateral. That was the result after the first clip. So we decided to put a second clip just right beside. This was the final result at 3D TE, and this was the final result at the echo, with the two clips positioned one close to the other. So the final result of this procedure was quite good. So in terms of the dynamics, the V wave went from 25 to 20. At the echo post-op, the mitral regurgitation, which was severe, went to traces. The gradient was 3, which is really good. And at the echo pre-discharge, which was 2 days afterwards, the ejection fraction was still 70%, with an area of 1.3 centimeters and a gradient of 7, with no mitral regurgitation and small shunt. And 3 months follow-up, the ejection fraction was still preserved with an area of 1.1 and a gradient of 5.6 millimeters, with just traces of mitral regurgitation.